but the P is silent there. Now, it's very simple here. Just let the name help you. So for hemothorax, just think hemo meaning blood, like hemoglobin. Blood collects in the pleural space, which is that space between the lung itself and the chest wall here, resulting in the lung collapsing in on itself from all the pressure buildup from the blood. Now, the key sign is dull resonance upon percussion, like tapping a paint can or a jug of water. So the memory trick here is the double L's. Just think L for dull resonance as L for blood or even fluid, sounding sort of like tapping a paint can or remember that jug of water from all that fluid buildup, especially blood. Now for pneumothorax, pneumo think lung, like pneumonia. The lung collapses due to air in the pleural space. Now the key sign here is hyperresonance, like tapping a hollow drum or a hollow tree. So the memory trick is the double H's. H for hyperresonance, just think H for high air. Now lastly, tension pneumothorax. This can result from an open pneumothorax, where air gets sucked into the pleural space when breathing in, and the air gets trapped and it can't get out. This is known as a sucking chest wound. Now, this typically happens from a penetrating chest trauma, like a gunshot wound, a knife stabbing, or something else that leaves a hole in the client's chest. Now, this is commonly seen in the hospital setting when we prematurely disconnect a chest tube. Now, a side note here and a general Nclex tip. Do not remove anything that penetrates the body. We always leave it in place. We never pull out a penetrating foreign object, since the client could bleed to death. Now, whatever the cause, the air pressure within this lung space can get so great that it collapses the lung, as well as, key terms here, it pushes the trachea and the organs to the side. This is known as tracheal deviation. So just think of the double T's. T for tracheal deviation, T for tension pneumothorax. Now for the common general signs and symptoms for all these conditions, we typically see dyspnea, that shortness of breath, tachycardia, that fast heart rate, tachypnea, that fast respiratory rate, as well as diminished breath sounds on the affected side, which makes sense because that side of the lung is either filled up with blood or with air. Now, Hesse had a question about this. During central line placement, the patient develops dyspnea and tachypnea, and the provider asks for a chest tube tray. The answer is suspected pneumothorax, that popped lung. Now, speaking of Mr. Chest Tube himself, the number one treatment here is obviously a chest tube. But for open pneumothorax, also referred to as a sucking sound coming from the chest, the key treatment here is, write this down, cover the wound with an occlusive petroleum gauze dressing, and here's the key, tape on 3 sides, never 4 sides, always 3. This must be done first immediately to prevent air from being sucked into the chest during inspiration, causing that deadly tension pneumothorax that pushes the trachea to one side from all that pressure. So remember, we have to implement this 3-sided occlusive dressing first, and then chest tube insertion can be coordinated after.